right. Welcome, everybody. It's my pleasure to introduce to you Dr. Caitlin Rittenhouse, who's a fourth-year resident physician in the Department of Obstetrics and Gynecology. Caitlin is from Lancaster, Pennsylvania, and she completed her undergraduate studies in Philadelphia prior to migrating south to UNC for her medical training. During medical school, she completed a one-year NIH Fogarty Fellowship with the UNC Global Women's Health Group, working in Lusaka, Zambia, studying HIV-associated preterm birth and functioning as project manager for the Zambian Prematurity Prevention Study, or ZAPS. She has continued this work during her residency training through the OGIG Global Health Scholars Program under the mentorship of Drs. Jeffrey Stringer and Joni Price. Welcome, Caitlin. It's a pleasure to have you, our speaker today.
Wonderful. Thank you. I'm going to quickly share my screen, and then we'll get started.
Somebody maybe, okay.
All right. Can you see the screen now? Excellent. All right. Hi, everyone. Thank you so much for the wonderful introduction. As I was introduced, I'm Caitlin Rittenhouse. I'm a newly minted fourth-year resident in the Department of Obstetrics and Gynecology, and I've been privileged to be a member of the 2020 to 2022 Global Health Scholars cohort. And I'll be presenting some previous and ongoing work partially made possible through this scholarship. And I believe that I'll be ending a little bit early today, but I'm definitely welcome any questions at the conclusion of this talk. The topic on which I'll be presenting is maternal HIV, antiretroviral timing, and spontaneous preterm birth in an urban Zambian cohort. This is an outline of the topics that I hope to cover today. So starting with some background, briefly, preterm birth, or birth prior to 37 weeks gestation, is the world's leading cause of neonatal death. Women living in Africa and South Asia carry the highest burden of preterm birth, where clinical infrastructure is often ill-equipped to care for premature newborns. In sub-Saharan Africa, preterm birth rates are among the highest in the world. Additionally, maternal HIV, which is endemic in sub-Saharan Africa, and exposure to antiretroviral therapy, or ART, have been associated with elevations in prematurity risk. In normal pregnancy, using a simplified figure at the right, the first trimester is characterized by a pro-inflammatory phase when implantation and placentation occur. The immune response transitions to an anti-inflammatory phase in the second trimester when maternal tolerance to the fetal allograft is prioritized to promote fetal growth and development. In the third trimester, renewed inflammation leads to uterine contractions and parturition, or childbirth. Additionally, the vaginal microbiome has been demonstrated to decrease in diversity as lactobacilli becomes the predominant species during the mid-trimester. Lactobacilli inhibits binding of other bacteria to epithelial cells and produces lactic acid that kills or inhibits the growth of many other bacteria. Nearing birth, there's a subsequent increase in microbiome diversity and decrease in lactobacilli. The majority of preterm birth are spontaneous, without a known cause. However, abnormalities in the normal immune response and vaginal microbiome have been posited as potential etiologies. The mechanisms by which intrauterine infection and inflammation lead to spontaneous preterm birth may be related to innate immune system activation, which through a complex network of cytokines, chemokines, and other signaling molecules promote cervical ripening, uterine contractions, and amniotic membrane rupture. Intrauterine infection, which may be overt or subclinical, chronic inflammation, and immune activation, as well as vaginal dysbiosis, or the displacement of optimal vaginal microflora by anaerobic or diverse bacteria, have been associated with spontaneous preterm birth. So moving on to the objectives of this research. Although the relationships between inflammation and vaginal dysbiosis with spontaneous preterm birth have been previously reported, few studies have been conducted in HIV-infected or African cohorts where the burden of preterm birth is the highest. Our objectives were to 1, characterize local and systemic inflammation, and 2, characterize vaginal microbiota in the mid-trimester in an urban Zambian antenatal cohort. We sought to assess alterations associated with HIV and ART, as well as to assess the association with spontaneous preterm birth. Our hypothesis was that HIV infection disrupts the normal immune system and vaginal microbiome in the mid-trimester and leads to immune activation and vaginal dysbiosis, which may at least partially explain the elevated preterm birth risk in this population. Next, I'll briefly describe our methods. The Zambian Prematurity Prevention Study, or ZAPS, is an ongoing prospective antenatal cohort at the University Teaching Hospital in Lusaka, Zambia. Briefly, ZAPS participants are enrolled in early pregnancy, receive comprehensive antenatal care, lab testing, biologic specimen collection, and ultrasound to establish gestational age through a study-run clinic. All deliveries prior to 37 weeks gestation are classified as either provider-initiated or spontaneous by an on-site obstetrician. In the first phase of this study, 1,450 women were enrolled. Approximately 78% were HIV uninfected, noted in the Carolina blue as HIV negative. 15% were HIV infected on preconceptional ART, annotated as HIV positive pre-ART in the teal, and 7% were HIV infected not on preconceptional ART, annotated as HIV positive post-ART in the dark blue. These 3 colors and terms will be used throughout the remainder of the presentation. All participants with HIV diagnoses are counseled and referred for appropriate antiretroviral therapy and prevention of mother-to-child transmission services. At subsequent prenatal care visits, initiation of ART is confirmed if participants were not on preconceptional ART. This study has ongoing approval by the University of Zambia, Biomedical Research Ethics Committee, and the University of North Carolina's Institutional Review Board. ZAPS study specimens are periodically shipped from Zambia to a sister biorepository at UNC, where we maintain a duplicate archive. For this study, we used specimens available in the initial ZAPS biorepository shipment. We defined our exposure as a 3-level variable that characterized participants by HIV serostatus, and among those infected, by timing of ART exposure, pre and post-conceptional. We excluded all provider-initiated preterm birth, for instance, preterm deliveries via induction or cesarean section for fetal status or maternal complications, as these preterm birth have a different pathophysiology than spontaneous preterm birth. We used a double sampling technique of eligible specimens that included all participants who were HIV infected and all participants with spontaneous preterm birth. Among remaining HIV uninfected participants delivering at term, we selected specimens at random. All analyses were performed using inverse probability sampling weights to account for this sampling technique. We analyzed specimens from enrollment, which was a 16 to 20 week visit, and among HIV infected women, we repeated analyses from a 24 to 34 week visit. For our cytokine analysis, we analyzed pro-inflammatory and anti-inflammatory markers in paired plasma and vaginal specimens. From a biostatistical perspective, the analysis of cytokines is challenging because of strong correlations between cytokines, particularly those with similar underlying biologic processes. Factor analysis is a multivariate statistical technique that reduces a large number of intercorrelated variables into a smaller set of independent clusters underlying physiologic relationships. As the biologic actions of cytokines can be broadly classified as either pro or anti-inflammatory, we performed a confirmatory factor analysis, which is a hypothesis-driven approach developed to assess whether associations among many variables confirm our hypothesized underlying factors. So we use this confirmatory factor analysis to generate pro-inflammatory and anti-inflammatory scores. Moving on to our vaginal microbiome analyses, we quantified relative abundance and diversity of bacterial taxa by genome sequencing on enrollment and repeat vaginal swab specimens on the same women included in our cytokine analyses. We identified community state types, or CSTs, by hierarchical clustering. These are methods of grouping similar microbiota that are established in the literature. We also calculated the Shannon Diversity Index of specimens, which is a measure of microbiome diversity, calculated using the number of species and their relative abundance. All staff performing laboratory analyses were blinded to baseline characteristics and clinical outcomes. So moving on to our results. In results slides, I have highlighted our key findings in gray boxes, as well as attempted to provide useful illustrations where appropriate. Moving your attention to the graphs, with the y-axis representing the vaginal pro and anti-inflammatory scores, which again is a measure of local inflammation. By default, the estimated factor scores have a mean of 0. Thus, factor scores cannot be interpreted in absolute terms, but are instead relative values. For example, a factor score of 0 does not indicate the absence of inflammation, but rather represents the average inflammation of the group. On the basis of this model, an individual with a positive vaginal pro-inflammatory score is assumed to have increased vaginal inflammation as compared to the mean. The x-axis represents our 3 exposure groups, again including HIV uninfected, HIV infected on preconceptional ART, and HIV infected on postconceptional ART. We found that at baseline, HIV infected women on postconceptional ART had higher vaginal pro and anti-inflammatory scores than HIV uninfected women, while no difference was observed with HIV positive women on preconceptional ART. Unsurprisingly, we found strong correlations between pro and anti-inflammatory scores. The small graph in the right upper corner of the slide is a scatter plot of the pro and anti-inflammatory scores showing this association. As our pro-inflammatory score was created using more immune mediators or cytokines and felt to be a more robust measure of local inflammation, we used this score in subsequent modeling. In trying to again demonstrate what we found using inflammatory patterns in healthy pregnancy for reference, what we see using the figure on the right is that HIV positive women with postconceptional ART exposure have higher inflammation in the mid-trimester than their HIV negative counterparts. HIV positive women with preconceptional ART exposure trended towards higher inflammation in the mid-trimester, but did not achieve statistical significance. Moving on to our longitudinal analysis, in the subset of HIV-infected women, we compared changes in inflammatory scores between baseline and repeat visits. Again, to orient you to this box plot, the y-axis represents a delta inflammatory score, meaning that we took the inflammatory score from a 24 to 34 week visit and subtracted the inflammatory score from the 16 to 20 week visit. Consequently, a positive delta inflammatory score represents an increase in inflammation from baseline to repeat measures. The x-axis again represents our exposure groups. We found that women on postconceptional ART had a greater increase in vaginal inflammation between baseline and repeat visits compared to those continuing preconceptional ART. Again, trying to give a visual of what we found, women with postconceptional ART exposure not only had higher baseline vaginal inflammation, but we see that they actually have an increase in vaginal inflammation between baseline and repeat collection time points. In vaginal microbiome analyses, our group quantified relative abundance and diversity of bacterial taxa using community state types, or CSTs, which are groupings of microbiota with similar composition and abundance. The graph represents the proportion of vaginal microbiomes with respective community state types on the y-axis, with again exposure groups represented on the x-axis. We found that anaerobe dominant community state types were more prevalent in HIV positive women on both pre and post-conceptional ART compared to their uninfected counterparts, as evidenced by the green, orange, and yellow community state types, making up the majority of the HIV positive microbiomes. Additionally, HIV infected women had less lactobacillus species, which are represented by the burgundy and blue community state types on this graph. We see these differences in the HIV infected women with preconceptional ART exposure, but these differences become more stark in the HIV infected post-conceptional ART group. Additionally, as demonstrated by the graph on the left with Shannon Diversity Index, a measure of microbiome diversity represented on the y-axis, and community state types represented on the x-axis, we found that anaerobe rich community state types, again represented in green, orange, and yellow, had higher Shannon diversity indices than the lactobacillus rich CSTs in blue and burgundy, meaning that anaerobe rich community state types have increased microbiota diversity than lactobacilli rich community state types. Using the graph at the right with Shannon Diversity Index, again represented on the y-axis, and exposure groups on the x-axis, we found that HIV positive women on both pre and post-conceptional ART had higher Shannon diversity indices than their uninfected counterparts. Again, this difference is more pronounced in post-conceptional ART exposed women. So trying to give a visual for these findings, HIV uninfected women had increased lactobacilli-rich vaginal microbiomes during the mid-trimester, which is the physiologic change we expect in normal pregnancy. However, HIV-positive women had decreased lactobacilli and increased microbiome diversity, which are considered to be inflammatory states. This difference is more pronounced in post-conceptional ART-exposed women. Moving on to associations with spontaneous preterm birth, using logistic regression to calculate unadjusted and adjusted odds ratios, with adjusted odds ratios controlling for HIV serostatus, ART exposure, prior preterm birth, maternal age, and BMI, we found that increasing vaginal inflammation is associated with spontaneous preterm birth. Plasma inflammation or systemic inflammation did not differ by HIV or ART exposure groups and was not associated with spontaneous preterm birth in our study. And all of our analyses were not significant, so these findings were largely excluded from this presentation. Additionally, we performed Poisson regression to obtain unadjusted and adjusted prevalence ratios of the change in Shannon Diversity Index. And we found that Shannon Diversity Index increased between baseline and repeat collection time points in women who went on to have a spontaneous preterm birth. Unsurprisingly, given the trends that we observed in our data, we also found that vaginal microbiome diversity was positively correlated with vaginal inflammation. So trying to summarize all of our findings, the big picture, as summarized using the figures at the right, in the mid-trimester, pregnant women living with HIV with post-conceptional ART exposure exhibit higher inflammation and higher relative abundance of anaerobic species and increased microbial diversity in the lower genital tract as compared to their HIV uninfected counterparts. We also found that vaginal inflammation is associated with vaginal microbiome composition, and both vaginal inflammation and increasing microbiome diversity are associated with spontaneous preterm birth in our urban Zambian cohort. These data support our working theory that HIV infection leads to local immune activation and altered vaginal microbiome. These findings may at least partially explain the elevated preterm birth risk in this population. Additionally, our data support ART as being at least partially protective of local immune activation and anaerobe-rich microbiota in pregnant women living with HIV. In HIV-infected women with post-conceptional ART exposure, they demonstrated more pronounced changes in local inflammation and vaginal dysbiosis. However, many women with diverse vaginal microbiota and inflammation still deliver at term. Consequently, further research is needed to investigate this relationship and to identify interventions. And we're currently undertaking more comprehensive analyses in a much larger sample of the ZAPS cohort to better characterize these interactions. So to briefly also discuss some ongoing research and other research performed with the UNC Global Project Zambia team on HIV-associated preterm birth. And an additional ongoing project supported by the OGHE Fellowship is the study of allostatic load in HIV-associated preterm birth. A growing body of research suggests that adverse perinatal programming by chronic or repeated maternal stress may increase the risk of spontaneous preterm birth and fetal growth restriction. Allostatic load is part of a theoretical framework that attempts to capture multi-system physiologic wear and tear, or describe the detrimental effects of accumulating stress, resulting in a degradation or dysregulation of physiologic function. Allostatic load has been proposed as a useful concept for understanding the pathophysiology and prediction of adverse pregnancy outcomes, including spontaneous preterm birth. And it may prove a useful tool in identification of targets or prevention of spontaneous preterm birth. This project is in an early stage, but will add to our understanding of the potential impact of chronic maternal stress on HIV-associated preterm birth. Additionally, there are several projects led by both Dr. Jeffrey Stringer and Joni Price with UNC Global Project Zambia, investigating interventions to decrease preterm birth in HIV positive women. 17-alpha hydroxyprogesterone caproate, or 17P, is a progesterone formulation, which is, as its name says, a progestation hormone which supports pregnancy growth and promotes uterine quiescence or reduces early contractions. 17P has been shown in some trials to reduce early delivery among women with a history of spontaneous preterm birth. In the IPOP study, or Improving Pregnancy Outcomes with Progesterone, 17P was investigated as an intervention to reduce preterm birth risk among women with HIV. This was a randomized, double-blind, placebo-controlled trial in pregnant women with HIV at the University Teaching Hospital and Kamwala District Health Clinics in Lusaka, Zambia. Eligible participants were randomly assigned 1-to-1 to receive intramuscular 17P or placebo once per week, starting between 16 and 24 weeks of gestation and continuing until delivery, stillbirth, or reaching full term, 37 weeks. The primary outcome was a composite of delivery before 37 weeks or stillbirth at any gestational age. 800 eligible participants were enrolled and randomly assigned to receive intramuscular 17P or placebo. Interestingly, 9% of both placebo and 17P groups had preterm birth or stillbirth, and no statistical difference was found. No serious adverse events were reported, and although 17P seems to be safe and acceptable to participants, available data do not support the use of this drug to prevent preterm birth among women whose risk derives solely from HIV infection. The low rate of preterm birth in this study in both randomization groups of 9% also warrants further investigation, as this is essentially half of that reported in other studies using a similar population. And lastly, antenatal vaginal progesterone is another formulation of progesterone supplementation that has been demonstrated to prevent preterm birth in women with a short cervix. However, vaginal progesterone has not been tested to date for the indication of maternal HIV, which is another risk factor for preterm birth. The vaginal progesterone VP study was a pilot feasibility study of vaginal progesterone to prevent HIV-related preterm birth in Lusaka, Zambia. Over a 1-year period, 140 pregnant women living with HIV were enrolled into a double-masked, placebo-controlled, randomized trial of daily self-administered vaginal progesterone or placebo. An end-line questionnaire was administered to all participants to assess acceptability and feasibility of this intervention. Of 131 participants who completed the questionnaire, 128, or 98%, reported that nothing was difficult when asked about the hardest part of using the study product. When given a hypothetical choice between vaginal and injectable progesterone, 74% chose daily vaginal progesterone. Most interviewees reported no difficulties with using the study product. Others cited minor side effects and surmountable challenges. Participants who reported preference of a vaginal medication over injectable described familiarity with the vaginal product as the reasoning for this. They also described a fear of needles and resulting pain and inconvenience of a weekly clinic visit. Consequently, vaginal progesterone was found to be an acceptable intervention in this study, but has not been specifically studied with respect to decreasing risk of preterm birth in this population, and is certainly an area for further study. And with that, I'd like to thank my mentors, Jeff Stringer and Joni Price, as well as the ZAP study staff in Lusaka, Zambia, who were all incredibly instrumental in this research. Additionally, Christina DeParis, Julie Nelson, and Elizabeth Stringer from UNC Chapel Hill, and Bellington Vuolika, Margaret Casaro, and Humphrey Mwape from UNC Global Project Zambia have been very instrumental in these projects as well. Additional thanks to the OGHE Scholarship for supporting these projects and hopefully supporting a global health elective in this fall when restrictions for travel we're hoping will loosen, and references for the projects are included below. And with that, I will take questions.
Great, Caitlin, thanks so much. Really well organized. And it's just good to see how much work you were able to get done despite not being able to travel. So I have a couple of questions, but I will open it up to others first.
I have a question, Caitlin. Can you hear me?
Yes.
Yeah.
Congratulations. That was a fantastic presentation, really well done. You packed so much information in there and explained it really beautifully. And it's a very interesting project. And my question is about, actually, I have two questions. One is just more generally, I'm not sure with your the restrictions on travel, if you can, how much you can comment on this, but like how did the aspect of cross-cultural work and exchange play into this particular project in your experience? But more specifically about your specific research that you presented, I'm just curious about, you mentioned the difference between the group that was on ART before conception and then the group that only started ART during pregnancy. And if you think there might be other factors like confounders that could potentially explain some of the differences you saw between those two groups that aren't actually related to the, the ART themselves, but is there something else different about, the people who were already on our ART, other factors about maybe their healthcare access or other things related to that?
Thank you. Really good questions. So the first question about cross-cultural impact of the data collection and of the study. Most of this analysis was all done using specimens that were previously collected, and these assays were actually performed in the United States using the biorepository that had been shipped to Chapel Hill. The study itself, I was fortunate to actually be in Zambia during this phase of the study with my Fogarty Fellowship in medical school. And I think a really wonderful aspect of the ZAP study is that it is mostly run by Zambian midwives, and it essentially functions as a replacement to their prenatal care through government-run clinics. And so actually, I think that the actual clinic flow and data collection is performed in such a way that is very culturally sensitive and actually very consistent with prenatal care provided or standard of care provided in Zambia, with the exception being that I think our clinic definitely has more resources given that it is funded internationally. But the actual running of assays and everything was performed in the US. And so that certainly was, I think, part of the reason we got the results in a timely fashion, whereas part of the reason our allostatic load study has been hitting a lot of hurdles is that we're actually running all of those assays through a lab in Lusaka, Zambia, which we have been waiting on data from similar specimens from for months and months and almost a year at this point, with different hurdles that we've encountered with getting our assays run. So certainly I think if we had run all of these analyses in country, our time frame would have been significantly delayed just due to the resource limitations internationally. Your second question, and give me a moment to remember what it was.
I can say it again. Sorry, that wasn't to throw two questions at you at the same time. And that's very interesting about the first one, because I was curious about the analysis, whether it was possible to do analyses in country. So thanks for bringing that up. My second question was about, do you think there's any confounders that between the two, the pre and post ART, and that could explain?
Yes, excellent question. So I think my hypothesis based on this data would be that there is some sort of immune reconstitution, which has been described in the literature with ART initiation, with the initiation of antiretroviral therapy actually leading to a like supra-inflammatory state immediately upon initiation that subsequently kind of resolves over time. And so my suspicion is that the women on preconceptional ART had kind of baseline control of their immune state, whereas those that initiated in pregnancy were confounded by that initiation occurring concomitantly with their pregnancy. So that would be my suspicion for the reason that we found the results that we did. But certainly there, as you allude to, I expect that there is also confounding factors, being that women who have not initiated ART may have additional resource limitations and or other social complications that have been the reason they didn't initiate ART prior to pregnancy, and or have not been in the healthcare system and were not actually diagnosed prior to pregnancy. And so I think that, as you allude, it's probably multifactorial. And I think that hopefully our allostatic load looking at chronic maternal stress will also kind of give us some information regarding the baseline social determinants and chronic stress that the women in these two groups have, and may inform that finding more.
Great, thanks. Other questions, thoughts? Mike, do you want to add anything? Give you a chance since you're there. If not, I have two things, Caitlin, I was going to ask. Knowing that a lot of women are also on treatment for opportunistic infections, I don't know how advanced the women's study were, like how could that be a confounder? Do you know? You didn't sort of note how advanced it was, and maybe that information is not available to you, but just knowing how vaginal microbes are affected by other antiviral agents.
That is an excellent question, and certainly a limitation of the ZAP study is that viral loads were not routinely collected on women. We did try to obtain these through the government-run ART clinics, but do not have reliable information on all of our HIV-infected women, unfortunately. And this is definitely a limitation that was identified, unfortunately, later on in the study when we were looking at sub-analyses. And something that we're addressing in subsequent phases of the ZAP study. We will have viral load data on that, which will be incredibly helpful to further understand this aggressive, or what the status of their HIV control is. So certainly that is a significant limitation, is that our only dichotomy was on ART exposure, not on viral load.
Together, yeah. And do you think the lactobacillus is just like a associated thing, or do you think it's actually protective? And would a study looking at introduction of lactobacillus or something is that a conversation you're having at all? Because I mean, looking at the progesterone, as you know, in the US, we're looking at whether progesterone really is effective or not, even though ACOG has continued to endorse it. I think studies are demonstrating that it's not. And the last thing we want to do is to introduce a global intervention that we've already decided doesn't work in the US. Any thoughts about that?
That is a great question. So I think the physiology that we attribute to the lactobacillus being beneficial is that it produces lactic acid that decreases the overgrowth of other microbiota, which have been associated with subclinical infection. And so my suspicion is that it is actually protective. Given we know its association with the pH of the vagina, and that is also associated with risk of preterm labor and subclinical infection. But I do not know of anyone to date looking at introducing lactobacillus, which is actually a very interesting idea. And certainly I think microbiomes in many sides of medicine is a hot topic for study, both like skin flora, GI, and now vaginal microbiomes. And so I think that this is something that, may be further investigated in the future, but to date, I'm not aware of anything, but I have not looked specifically into that.
Yeah, I just think it's really interesting. I mean, we're only beginning to learn in neonatology what the gut microbe is responsible for. And there's conversations about introducing microbes. So just interesting.
Yeah.
All right. Others with questions or thoughts? Thank you for putting a lot into this despite a small audience. And Moira we have these recorded. So we'll be sure to post them and be able to follow up that way.
Perfect. Thank you so much.
Yes,
All right.
if you could send your PowerPoint, we will add that. Sometimes people prefer to look at the PowerPoint and not the whole recording. So,
all right.
Thank you.
Great.
Yes, thank you. Bye.
All right, Caitlin, thanks for fitting it in. Yeah.
Bye.